Okay, so in chapter 29, we're going to be talking about the development. So basically the events that happen after sperm and egg fuse. And then we'll also be talking about pregnancy and the effect of pregnancy on the mother, as well as trying to reorganize my windows here, as well as some postnatal changes that happen in the baby after the baby is born. So first we're going to look at the prenatal period, and this is the period that happens before birth. And the prenatal period we can divide into three phases or three sub-periods. And these include pre-embryonic period, embryonic period, and fetal period. The pre-embryonic period is going to include the first 2 weeks after fertilization. And we call this pre-embryonic period because there's not really an embryo that has formed yet. It's basically cells that are becoming an embryo. Then we have embryonic period, and this is weeks 3 through the end of week 8. And in this phase, we are seeing an embryo. And then week 9 begins the fetal period. And so from week 9 until the end of pregnancy, then we talk about the fetus. So make sure that you know these numbers. Make sure that you know that fetal period begins at 9. Sometimes, for some reason, people want to say 12, week 12, but week 12 is not. That's not when the fetal period begins. That's that. So those are 3 periods. So we'll be talking about each of them individually here. Let's talk about fertilization first. So I've mentioned the word fertilization. Fertilization means when the sperm and the egg fuse together and they create the first cell of the new organism. Remember, sperm and egg are both haploid cells, so they are carrying half of the chromosomes, or one set of chromosomes. So you get one set of chromosomes from the sperm, one set of chromosomes from the egg, and when they fuse together, then we get the first diploid cell. This first diploid cell is known as zygote. Fertilization usually happens in the ampulla of the fallopian tube. Okay, now this is fertilization. I'm not talking about implantation. Okay, you don't want implantation to happen in the tube, but fertilization happens still within the fallopian tube, and it's in the ampulla, so it's not very far down the fallopian tube. The sperm, something that we should mention is that the sperm stays alive for about 3 to 4 days. I have seen the literature mentions 7 to 10 days even. But the oocyte is only alive for 24 hours. So as the oocyte is released, if it's not fertilized in 24 hours, it will degenerate, it will fall apart, it will die. So it seems like there is a very short window for a woman to get pregnant, but that's where the longer lifespan of the sperm comes in play. And so because the sperm has longer lifespan, if it's already there when the oocyte is released or ovulated, then pregnancy could occur. Okay. Before the sperm is able to fertilize an egg, it has to go through a process known as capacitation. And capacitation is kind of like a conditioning of the sperm. It basically involves removal of some of the glycoproteins and some other proteins from the surface of the sperm. This is going to kind of uncover the acrosome. So if you remember from sperm has an acrosome cap there that carries chemicals that will ultimately help it burrow through the corona radiata and the zona pellucida. Well, when the sperm enter the female body, there are chemical changes basically that are going to happen there. And one of those is the removal of those glycoproteins and making the sperm able to fertilize the egg. And this usually takes about a few hours. And then sperm is ready to go. There's actually, so you know that a male releases anywhere between 200 to 500 million sperm with each ejaculation. And however, not all of these are actually going to get to the oocyte. There are various things that the sperm face as they enter the woman's reproductive system. One of the big things is the acidity. inside of the woman's vagina. So this acidity is going to kill a lot of sperm, so that will greatly reduce the number. Some sperm are just not functioning well, like their flagella might be messed up or such. Some of them are going to go into the wrong fallopian tube, even though the oocyte is actually releasing chemotactic signals to attract the sperm. Some of them are still going to go the wrong way. Some of them get churned by the uterus of the woman, so they get damaged or destroyed or just redirected due to that. So only a few hundred sperm actually make it to the actual oocyte. So majority of them is going to die. So that's that. So once the sperm get to the oocyte, now they're facing the corona radiata cells. And then underneath the corona radiata is going to be zona pellucida. That's that kind of a protein jelly-like layer that surrounds the oocyte. And so sperm begin to burrow and push through the cells of the corona radiata. They're getting to the zona pellucida, and then the chemicals in the acrosome cap are going to help the sperm get through that zona pellucida. Once a single sperm burrows through that zona pellucida, the zona pellucida goes a very quick and sudden change, and it is going to harden. It will, and so some sperm might be like halfway through, right? But as soon as one gets completely let me rephrase this, because it's not the actual whole sperm that's going to enter, but once the zona pellucida is dissolved enough, it is going to harden this zona pellucida. And so those that are kind of halfway through, they're going to just get stuck there and they will die. So right underneath the zona pellucida, you have the plasma membrane of the cell. And so as the sperm gets through that zona pellucida and comes in contact with the oocyte's plasma membrane, their plasma membranes will fuse and the nucleus from the sperm will enter the cell. Okay. This event is going to trigger end of the meiosis II for the oocyte, because at this point, this oocyte that has been ovulated is in metaphase 2. So it hasn't completed the second part of meiosis. And so as soon as that nucleus gets inside, past that cell membrane, the oocyte will complete the meiosis II, and it will produce that second polar body, which will degenerate. And then the nucleus of this of that ovum and the nucleus of the sperm will fuse together, and this is going to be your first diploid cell, which is known as the zygote. Okay, so you can see that right here. This is our zygote here. All right, and that's our first diploid cell. That's the name of that cell. Zygote will stay in this phase, in this single cell phase, for about 24 to 30 hours. So it's not going to divide right away. It's going to stay like this for 24 to 30 hours, and then it will divide. And the division that it's going to go through is a mitotic division. It's mitosis. It's going to produce two identical cells. However, we call this division cleavage because if you notice, and maybe that's not super obvious to you on this circle here, but the two cells that are produced after that first division are going to be roughly half of the first original cell. So they are not going to, the whole structure is not going to be increasing in size. And then you get 4 cells, and then you get 8 cells. So with each division, you're multiplying the cells, but the whole structure stays the same size. So the cells are there's more and more cells, but they're getting smaller and smaller. And this is partly due to the fact that the zona pellucida is still surrounding this, right? So you don't have room for larger cells. So zona pellucida is still there, keeping that structure relatively the same size as it's moving through the fallopian tube. Eventually, we reach the 16 cell stage. This is known as the morula, and this is a solid ball of cells, pretty compact cells here, and they will divide some more, and eventually this solid ball of cells reaches the uterus. As it reaches the uterus, at this point, the zona pellucida is not going to last forever. So zona pellucida is starting to break down as the whole structure moves through the fallopian tube. And when the morula gets into the uterus, it will, the zona pellucida will break, it will degenerate, and the solid ball of cells that you had is now going to be filled with fluid that's present in the uterus, and it will push the cells of the morula apart. So you had solid ball of cells, and then boom, it's going to pop open into a hollow ball of cells, and this is known as the blastocyst. So that's what you see right here. So blastocyst is hollow. There is a single layer of cells that is creating that structure, and then you have this cluster of cells here, this blue area that's going to be known as the embryoblast. This is what's going to give rise to the embryo, as well as some extra embryonic membranes. The outside of the blastocyst will become burrow into the, the whole thing will burrow into the uterine lining, but it will become trophoblast. Okay. So here is part of table 29.1. That's kind of looking at those events a little closer. And yeah, so you can see that right here. So the outside of the blastocyst is trophoblast, inside is the embryoblast, and that happens in the uterus there. And then you can see the implantation. Implantation starts happening about day 7 after fertilization. So it takes about 7 days for the zygote to start dividing and forming the morula, and the whole structure moves along the fallopian tube. And then implantation begins about day 7, and it ends somewhere around 9 or 10 days after fertilization. So it takes a while. It's not like it's just going to slip into the uterine lining in one step. It actually kind of grows into the uterine lining, and that's why this takes a little longer than just it like literally merging into the uterine lining. Here's a microscope, electron microscope picture of the oocyte and sperm trying to get through to it. Okay, and here's a drawing of that. Some more, but I wanted to get to this, and unfortunately, it is cut up my picture in two. But in your textbook, if you have, I don't know if you have a hard copy of your textbook or not, but this is figure 29.4, and so in your text it's all on one picture. But we start with the fertilization here, and notice like these lines right here, this one and this one, they're pointing to like where this stuff is happening in the fallopian tube. Okay. So that's kind of how you read this. And notice that as it's moving, the structure is moving along the fallopian tube. It doesn't grow in size. Okay, it stays relatively the same. And then we have the blastocyst once we get into the uterus here. And then the implantation. So this nicely visually shows you that the structure remains the same size, and kind of shows you what happens where at which point here. A little closer look here at implantation and some changes that the blastocyst is going through. So there's a lot of changes, a lot of different names that are coming up, from one day to another even. So we have the blastocyst, which blastocyst only has embryoblast and trophoblast before it begins to implant into the functional layer of the endometrium. As it begins to implant, so when it comes in contact with the mother's with the uterus, the trophoblast is going to start to differentiate, and it will create these two layers. There is cytotrophoblast, and that's this layer right here, right there. It's the inner layer of the trophoblast on this side. Okay, So it's between the syncytial trophoblast and the embryoblast here. It's a lot of blasts, okay? So make sure that you're keeping them pretty straight, okay? The syncytial trophoblast is going to start, like those cells of this layer start multiplying, and they're basically growing into the uterus. Think about it as like when a plant creates roots almost, okay? So the syncytial trophoblast is getting larger and larger here, right? And that's because those cells are multiplying and they're invading that uterine lining. And ultimately, as this is happening, the blastocyst, the whole thing is getting pulled inside, okay? And as this is happening, we start observing some differentiation of some layers from the embryoblast. So you can see there's amnion forming, and it's not labeled in this image right here yet, but that's going to be the amnion. And then the yolk sac right here, which is our first extra embryonic membrane that forms. And then wherever they come together is the bilaminar germinal disc, okay? So we have a hypoblast and epiblast here that creates a bilaminar germinal disc, and that's this structure right here. This will eventually become trilaminar embryonic disc. And trilaminar, it will correspond to the 3 primary germ layers, so ectoderm, endoderm, and mesoderm, okay? But at this point, initially we just have 2 layers, and then the 3rd layer develops a little later, a few days later, okay? And so here you can see at the last part here, day 9-ish, the whole thing is already inside of the uterine wall. And yeah, still have a bilaminar germinal disc. So we have that hypoblast and the epiblast here. Okay. So that's let's talk a little bit about the extra embryonic membranes. Not sure what, okay. This, by the way, shows you, oh, one other thing that I forgot to mention here, since now I'm looking at the hormones here, is that the syncytial trophoblast is going to be releasing the human chorionic gonadotropin. And this is the pregnancy hormone, okay? So that's the one that, when you pee on the stick, that's what turns the pregnancy test positive. The human chorionic gonadotropin is going to signal your corpus luteum to keep releasing progesterone and estrogen, okay? Because that's what it does. After ovulation, what's left from the follicle is corpus luteum, and it promotes uterine growth, and it makes it kind of nice and fluffy and inviting and highly vascularized. And so the human chorionic gonadotropin will tell the corpus luteum to keep doing this, because you don't want to shed uterine lining if blastocyst is beginning to implant. Okay, if you shed the uterine lining, you're shedding the blastocyst with it as well. And so corpus luteum does this and keeps the uterine lining going. And eventually, after about 3 months or so, placenta is large enough that it can release these hormones on its own and kind of takes over for the corpus luteum. Okay, so that's what I wanted to mention there. When we look at this, so here you can see some of the extra embryonic membranes here. So yolk sac is our first extra embryonic membrane to develop. It doesn't have yolk like if you're thinking about yolk in a chicken egg, it's not quite the same. Yolk sac here is responsible for blood vessels and blood cell formation, so for erythrocytes. It is also the place where the primordial germ cells, which will become sperm and eggs, future sperm and eggs, originate. It's in the yolk sac. So that's our yolk sac. Amnion is the membrane that encloses the embryo, and it produces amniotic fluid. This is going to prevent the embryo from drying out, and it also provides protection. It is closed up, so prevents bacteria from getting to the embryo, and also provides a bit of a cushioning to the embryo as well, and then later fetus. And then our third extra embryonic membrane. So extra embryonic means that it's not part of the embryo, it is around the embryo. The third would be the chorion, and chorion is what develops from trophoblast, and it's this it's like these branches right here, okay, that are projecting into the uterine lining. Okay, so that's the chorion. I mean, it's this whole thing. And then these branches really are called chorionic villi. They're still part of chorion. Okay. So that's that, and it's going to be part of the placenta. So when but placenta has the maternal side and the fetal side. So chorion will be forming the fetal side of the placenta and kind of blend with the endometrium eventually. Okay. So that's that, and here you can see the chorionic villus. It's so pretty. How they drew it here. So notice how you just have a single layer of cells for the most part here, that lines this up, and then you have all these blood vessels inside, and this is how the gas exchange and nutrient exchange is going to happen. So the blood comes to the area through the maternal artery, and then it fills these spaces, these sinuses right here. Okay, and the nutrients would diffuse into the fetal blood from the mom's blood, and carbon dioxide and waste from the embryo and then later fetus would diffuse the other way. And so that's kind of how that works. But it's important to have, relatively thin layer of cells that is creating that chorionic villus, so that diffusion can happen easily. And yeah, notice that mom's blood and the baby's blood do not mix. They're separated. You have the trophoblast cells that are separating the mom's blood from the baby's blood. And this is why, baby can have a different blood type than a mom. Okay. Their blood does not mix. The things move between the mom and the baby by diffusion. Okay. So that's that. And here you can see, a larger placenta right there on this side. Okay. So anyway, let's go on to the next part. Well, before I go over this, because we're not really going to talk about this folding very much, but for the placenta, I've already mentioned that placenta is going to be, exchanging materials between mom and the fetus. So what is being exchanged? Nutrients and waste, okay, respiratory gases as well, and antibodies. Antibodies also get exchanged through the placenta. So that's important to know. And I think we mentioned that when we talked about the immune system. And then placenta does begin to produce progesterone and estrogen, and takes over the production from the corpus luteum about 3 months in. The embryo and then fetus is connected to the placenta by first connecting stalk, and then it later becomes umbilical cord. But it's just connecting stalk when it's like really, really short, when it's not really a cord yet. And then at some point it changes into the umbilical cord. I'm not gonna ask you when the change happens, but that's that. And then here you can see, this is the table that kind of summarizes what happens during those first few weeks, the pre-embryonic and embryonic period here. And so you can see that week 4, you can see the head is forming. Here's the heart prominence. And so it looks like it's external at this point. Week 4, we would already have the electrical events that are going to be the heartbeat. So they're already occurring in rhythmical intervals at this point. Those electrical signals begin somewhere about 21 days after fertilization. And then you can see where the limbs are beginning to form. And here's that umbilical cord. And then weeks 5 and 8, you know, it's just becoming more and more human-like looking, right? So head is becoming more developed and more, you know, round. You can see the ear and the eye there. There's no sound yet. And also the the eyes are not seeing anything yet because it's that they're not developed. Sound, the embryo cannot hear at this point. It cannot actually hear until a little later in pregnancy because how do we produce sound? We need bones in our ears, right? To produce that sound. And so those are not, they're still cartilage, and so they're not producing the sound. And then the eyes also will develop later. So that's that. Okay, so for this, we're not going to talk about this folding or anything like that. There's too many terms here that just change from, you know, day to another day. And now you have a completely different terms. So, but just kind of be aware that like this view, you're looking at, like if you look right here, okay, you're looking kind of from the top, and you can see there's like this fold in the middle. And this will kind of fold on itself and eventually. So if we look at this, will look like this. And notice that mesoderm is forming right here, and this would be then that trilaminar embryonic disc. So at this point, like here, it's bilaminar. Okay, and here we have trilaminar. We see all 3 germ layers here, and these are the cell lines. And then right here, you can see a cross section. Okay, so this is the cross section here, and this is the embryonic disc in the middle. All right. I do want you to know what the different what the different primordial germ layers give rise to. So you can kind of skip over these, but this shows you kind of how that folding happens, how everything kind of comes together. Okay, so notice that it goes turns outwards and then comes together. And you see where the gut kind of forms right there in the middle. So this would be the cross section. But again, I'm not going to make you label that. Okay, so none of that is going to be on labeling. But this figure right here is important because when we look at the bottom part of this figure, this is another one of those that are split for me here. You have, you know, ectoderm. Ectoderm, I want you to know that it gives rise to your skin and various glands, nervous system as well. Okay, mesoderm, all muscle layers, okay, is going to be from mesoderm and some other things. And then endoderm is going to be the lining of the internal organs, as well as some glands also come from the mesoderm here as well. Okay, so make sure that you are able to match the different things that are coming from these different germ layers. Okay, that will be definitely on the exam. And that's about that for the development. Like when we look at fetal stage, so fetal stage begins week 9, and during the fetal development, the fetus simply grows, and you know, everything just continues to develop and mature as the pregnancy continues. So you don't have, I'm not going to ask you on major events of these, okay? So this is just for your information, this table 29.3, but I'm not going to ask you that yet. I mean, not yet. I'm not going to ask you that stuff. So I want to go and see if we can, if you remember this. Oh, there's only like 4 of us here. All right, so the question is, fertilization usually happens where? And we got a couple answers here. Are the other two people scared? Okay, so we have one vote for the ovary, we have one vote for the ampulla of the fallopian tube, and the 2 votes for the ampulla of the fallopian tube. And the correct answer is the ampulla of the fallopian tube. It cannot be in the ovary because the oocyte, if it's in the ovary, it's not accessible to the sperm yet. So it has to be ovulated. It has to leave the ovary for the fertilization to happen. So that's this one. Let's see. Let's see if you remember some of these. Okay, so the first question is, what is the first diploid cell of the new organism after the sperm and egg nuclei fuse? One person answered. 2 people answered. Good job. All right, the second question is, cleavage is the type of cell division where, and I know there's a lot of words in each answer choice, and there were 2 answers that both include that the number of cells increases. I mean, that kind of should be a given there because if it's a cell division, you can't really have a decrease in number of cells, right? So it's one of those, number of cells increases, but then what happens to the structure when the cleavage is happening? Cleavage is a special type of cell division where you increase number of cells, but I'm about to sneeze. Nope, I fought it off. Sorry. Anyways, the number of cells is going to increase, but the structure does not increase in size. And so the structure remains the same. Okay, so you get more and more cells and they get smaller and smaller. And so the overall size of the structure remains the same. Oh my goodness. And then let me see, what's this one? Okay, I have a couple more. I forgot to put them out earlier. Okay, a sperm has to undergo certain changes before it is able to fertilize an egg. What is this known as? Oh my goodness. Okay, who remembers? What does the sperm have to go through? That's the first question. And it starts with a C. Okay, I know that's not a very good hint. All of them start with a C. Okay, got a first answer there. And then for the second question, you can pick more than one. I think you should be able to pick more than one. So what all belongs into the prenatal period? Okay, some answers are maybe changing. All right, so let's answer that first question. A sperm has to undergo those changes before it is able to fertilize an egg. I was talking about capacitation. And so it has to do with the acrosome cap. So that one was there to, maybe see if if I can confuse you. But it has to do with the acrosome cap, where the glycoproteins are removed from the acrosome cap, but it's called capacitation. And then our second question, select all that are part of prenatal period. So prenatal period has three sub periods, and that is the pre-embryonic period is first, and that's the fertilization up to end of week 2. And then we have the embryonic period, that's week 3 through 8. And then we have the fetal period, which is going to be the week 9 until the end of pregnancy. Pre-fetal period is not really a thing that is used. I just made that one up. And postnatal period is after the baby is delivered. All right, so we reviewed some stuff. Let's go on. And now we're gonna talk about pregnancy. So what happens during pregnancy and so on. So the pregnancy is divided into 3 trimesters. It lasts 40 weeks, and it is these 40 weeks are counted from the woman's last cycle. So actually, the first 2 weeks, she's not really pregnant. It's just the oocyte is developing, right, and getting ready to be ovulated. But those are also counted in the 40 weeks. The symptoms of pregnancy vary from woman to woman, and even from pregnancy to pregnancy. So no 2 women are going to have exactly the same pregnancies. They're going to have different symptoms, but also symptoms with different children. Same woman with different pregnancies might have very different symptoms. Sometimes they say it's like, the boys versus girls. Like if the woman is pregnant with boy, she has some set of symptoms, and with girls it's different. But that's all kind of just the anecdotal evidence there. It's not really set in stone. It's just kind of a old wives' tales, right? So the changes that the woman is going through are happening generally due to the different hormones, that hormonal changes that are going on in the woman, because there is going to be a lot of hormones and hormonal changes there. So let's look at some hormonal changes that are happening. We know that HCG is being produced. This is a new hormone that's not being normally produced when a woman is not pregnant under normal conditions. There are some like diseases that can cause HCG being released, but normally a healthy woman that's not pregnant will not form or produce HCG. HCG is secreted by the blastocyst, and it mimics luteinizing hormone, and it tells the corpus luteum to keep doing its job, to keep releasing progesterone and estrogen so that the uterine lining is maintained. Other 2 important hormones are progesterone and estrogen. These are produced first by the corpus luteum, then they're produced by progesterone and estrogen. By the placenta. So placenta takes care of this from 3 months and on until the end of the pregnancy. The effect of progesterone and estrogen is going to be kind of a wide effect here that we see. It's going to suppress, these 2 hormones suppress luteinizing hormone and follicle stimulating hormone. This is important because you don't want your body to be maturing any more follicles and ovulate more follicles if there is a pregnancy established within the uterus. Okay, we're not designed to hold babies at different gestational periods. Okay. And so the follicle development will be paused or suppressed by progesterone and estrogen. Progesterone and estrogen are also going to promote the mammary enlargement pretty early on, actually. And they're going to promote uterine growth and fetal growth, and they're also going to have effect on integumentary system, like your hair and nails. So what women see is that their hair normally is going to stop falling out. So normally we have certain number of hairs that we lose every day, but during pregnancy, this is kind of put on hold. I'm not really sure why, but it happens. And so women generally have like fuller hair while they're pregnant. And also their nails, they might notice that their nails are getting just kind of stronger. Another thing that's kind of an odd thing for progesterone and estrogen to do is that women will experience loosening of joints. This is important to happen because loosening of the joints, especially your hips, is going to make the passage of the fetus through the birth canal easier. However, we also notice this loosening of the joints in other areas. Okay, it doesn't just target pelvis. And where it's most noticeable is in our feet. So women will notice that their shoes might not be fitting the same as they did before. And part of that might be attributed to some extra swelling going on during pregnancy, but also as the joints between the bones in our feet loosen up, the foot actually does get larger. And again, not everybody experiences this, but women can grow 1.5 size in in shoe size during pregnancy. And this might go back, it might go back just partially, it might not go back at all, so you just end up with the larger feet. So that's progesterone and estrogen. Another hormone that we should mention is relaxin, and relaxin has nothing to do with what its name suggests, because when you hear relaxin, that might make you want to think, oh, it's the one that relaxes the joints. No, okay, it has nothing to do with that. I think at one point maybe they named relaxin relaxin because they thought that's what it did, but relaxin actually promotes blood vessel growth. So its name has nothing to do really with its function, which is weird. A few more hormones. Corticotropin releasing hormone. This one is believed to play the role in length of pregnancy and timing of the childbirth. The corticotropin releasing hormone we know has an effect on aldosterone, so it will increase aldosterone, which will in turn cause increase in fluid retention in our body. And we'll see that this is going to be partial reason for why our blood volume during pregnancy goes up. But about that later. Okay. Another hormone, human placental lactogen. This one promotes metabolism of fatty acids rather than glucose, and it's going to also inhibit insulin in the woman. So more glucose remains in blood, and then it's available for the fetus. Glucose is the best molecule for energy, and since the fetus is still developing, it's easier for the fetus to break down and use glucose for energy than some other larger molecules. And so the woman's body literally will reach for other molecules and leave the glucose, more glucose for the baby. And then oxytocin and prolactin hormones, these usually we talk about them together because they play an important role in lactation, where oxytocin is responsible for breast milk ejection and prolactin is responsible for formation of the breast milk. Oxytocin also is the one that is responsible for uterine contractions during childbirth. So we'll see that that's going to, when the oxytocin begins to be released, that's going to stimulate the uterine contractions during childbirth. The changes in mom during pregnancy are going to include the growth of uterus. So there's going to be an obvious hypertrophy and hyperplasia. Hypertrophy means that the organ gets larger, and hyperplasia means that cell divisions are happening more frequently, which kind of has to go hand in hand with each other. There is the fact that the uterus is changing in size is detectable about 4 weeks after fertilization, just by external examination. The uterus, as it grows, it's going to push on everything around it. So when you look at this image right here, notice that the uterus doesn't just grow outwards, it also grows up. And so everything kind of gets pushed up. And so as the baby is getting bigger and bigger, you're feeling more and more squished. Okay. It's like everything is getting pushed to your throat almost. It's great. So anyway, this can cause a lot of gastrointestinal problems. It can cause heartburn, indigestion. It can cause constipation also because everything is pushing on, it can create some blockage and such. There's also going to be more urination happening, and this could be especially later on in the pregnancy because the uterus is on top of the bladder, so it's actually physically pushing on it. Or it can also be associated with the fact that we have increased aldosterone, we have increased fluid retention, you have more fluid in your body, and so even though you're initially going to be retaining it, because your body now has more fluid, you're going to have uh, more urination going on with that. The insulin resistance can cause gestational diabetes. So if the insulin resistance gets out of hand, it can cause gestational diabetes, and this means that it's the insulin is suppressed, or um, well, kind of suppressed too much, or inhibited too much, and there's too much glucose in the woman's body, a woman's blood, and too much of it goes to the fetus. And so one of the um, risks of gestation diabetes is that the fetus will get unusually big. Okay, that will just grow because too much glucose. Um, and so that plasma volume is going to increase about 50%. So because plasma volume increases, the cardiac output is going to increase because you have a higher blood volume now. So you're going to have to move more blood through the system. Many women experience varicose veins and hemorrhoids or edema. And this all has to do with the fact that you have higher blood volume now. There's more fluid in your vessels. And also, it's especially later on in the pregnancy, it becomes a little harder to move around. And so, to prevent these, it's good to stay relatively active within the reasons, okay? Not overactive, but not underactive either. Because remember, the skeletal muscle pumps, these are the mechanisms that are moving the blood through your system, right? So it will move the blood from your legs, you know, and as opposed to if you're not moving much, there's all this extra fluid in those vessels in your legs, and they can collapse if you're not, you know, moving that blood around. So, and the hemorrhoids are kind of like varicose veins, but they're in the rectal area. It's also collapsed veins. Edema is just accumulation of fluid. It's where you have, you know, too much fluid, swelling. You know. Women experience dyspnea, which is awareness of breathing, and just it's a little harder to breathe. This is because the woman has to increase her tidal volume about 30 to 40%. You need more oxygen now because you're not only supplying oxygen to your body, but also to the growing fetus. Also it becomes increasingly difficult to breathe because remember that fetus is pushing on everything, and so there's just not too much room to expand your lungs as easily as if you didn't have, you know, the fetus growing there. So not only do you have to expand your lungs more because your tidal volume is higher, but also it's more difficult because now everything is more squished. And then yeah, that's that for the changes in the mom. That's kind of summarizes that. But again, I said every woman has, like, you know, you might not have all of these symptoms, okay, but you know, the plasma volume does increase and the tidal volume does increase and all that. And to a degree to which it changes, you know, that's going to determine what your symptoms are during pregnancy. But pregnancy doesn't last forever, so eventually it will be followed by labor. There are several, we can talk about several different types of labor. We can talk about premature labor, false labor, or Braxton Hicks contractions. And I think your book says that Braxton Hicks are contractions of the false labor. A lot of times we kind of talk about Braxton Hicks as like separate category, because Braxton Hicks are contractions that might happen, like, you know, you just feel your stomach, okay, or your abdomen really contract. It gets really hard. You can feel that muscle contracting, but it doesn't usually hurt. It doesn't usually make you think that you are going into labor. Usually, now some of them, sometimes they could be painful, but most of the time it's just kind of like a practice contraction, and usually they don't hurt. False labor is when the contractions do begin and they're painful, and it seems like it could be it, like you're going to have this baby now. However, false labor does not show any progress as far as like your cervix changing. The contractions kind of remain about the same intensity. They're not getting stronger and stronger, and your cervix is just not doing anything. That would be false labor. Premature labor is labor before 38 weeks. And so anytime before that time, we talk about premature labor. And then true labor is where the contractions happen to be regular. They are not only getting closer together, they're also going to intensify. So they're going to be getting closer together, and each contraction will begin to last longer and longer. Labor is a positive feedback. So it's a process that's working towards a single outcome, okay, and that is the delivery of the child. Um, so yeah, in a true labor, you're going to see these contractions intensifying and getting closer together, and you're also going to see that cervix is changing, so that there are going to be cervical changes, and the changes we're talking about here are dilation and effacing. So dilation is the cervix actually getting larger, okay, so it will open up, and effacing is the cervix will thin out, and so we can't really see that on this image right here. We can't really see that on this image right here either, but you can kind of see it here maybe. Okay, so cervix is, see right here, it's partially dilated. I wanted to use the pointer. Okay, partially dilated right here, and it's getting thinner and thinner. Okay, and then right here, fully dilated. Okay, fully dilated cervix is the size of a bagel, outside of the bagel, not the inside. Okay, the outside of the bagel, that's a fully dilated cervix. It's 10 centimeters, and that's what you wait for before you start pushing here. Okay, there are, so let's go back to this, and this shows us kind of what hormonal changes are happening here as labor is beginning. And so here you can see that the cervix is not really dilated or effaced. Okay, it's closed up. Okay, but then later on you saw that it was getting pushed apart and getting thinner. So the stimulus for labor is going to be the release of this oxytocin. Oxytocin is released from hypothalamus. It's released from the mom's hypothalamus. It's released from the baby's hypothalamus as well. The oxytocin is going to do two things. One, it's going to stimulate the uterus to contract. As the uterus contracts, it's pushing the baby's head against the cervix. This stimulates more oxytocin release. Okay. Another thing that the oxytocin does is that it's going to act on the placenta. It will tell placenta to release prostaglandins. Prostaglandins are responsible for dilation of the cervix. So they're going to help with dilation of the cervix. The more dilated the cervix is, the more oxytocin is being released from the mom and from the fetus. Okay, so it's as I said, it's a positive feedback. Okay, oxytocin is being released. It's promoting the pushing of the baby onto the cervix, as well as the prostaglandins to open up the cervix. And as the cervix is being opened up, that promotes more oxytocin being released. Okay, so that's kind of how this whole thing works, and it will continue happening until delivery happen. The labor has three stages. It's dilation stage, expulsion stage, and placental stage. Dilation stage is waiting for the cervix to dilate. This is usually the longest phase, and it takes several hours usually for women to get to the fully dilated cervix. Some women are very quick in their labor, and they could have this baby in 2 hours or something like that. But generally, the dilation stage will last several hours. So you know how like in the movies they show a woman like she's not experiencing any contractions or anything, and then all of a sudden her water breaks, and then they barely make it to the hospital. Yeah, that's not usually how that happens. Okay. Because um yeah, it's usually not how it happens. It could. There are women that do labor quickly, but generally, even after your water breaks, you have a couple of hours at least. So, so anyway, so that's dilation stage. After dilation stage, so once the cervix is fully dilated, here comes expulsion stage. This can last anywhere from 30 minutes to several hours. Okay, this is really subjective because 30 minute expulsion stage is like the pushing part. Okay, so the baby is actually being expelled from the body. Crowning is the time of when, and then I guess we can look at the actual image right here. So crowning is when the baby's skull becomes visible, and the really pushing out the head is the hardest part probably. And yeah, it says like it says in the book it lasts 30 minutes to several hours. I know with like my first one, it took about 2 hours of pushing. That was a very, very long time. But my second one, she was out on the third push. So that definitely did not last 30 minutes. Okay. I mean, I was already fully dilated by then. So, so very, very different with, from pregnancy to pregnancy. And then after the baby is out, it's not over. Okay. We have to still get the placenta out. So there's the placental stage, and this is where you're delivering the placenta. This is what the placenta looks like. If you are bored one day, you can look up what all people can do with placentas. You can look up placenta bear. But there's various things that people do with placentas nowadays. I don't know. I just gave it to the hospital. But anyway, so placenta has to be delivered as well. Remember, placenta is a highly vascularized organ, and so after the baby is delivered, if you cut the cord, there's still blood going into the placenta, and so it's coming out. And so it's very important that placenta detaches in one piece. If it does not, which they will check once it comes out, they will check whether it's intact or whether it looks like it's ripped apart and needs, pieces of it need to be removed. So if it doesn't come in one piece, then they will have to remove whatever was left behind. And if it doesn't want to come at all, again, they will have to remove it somehow. And so they generally want you to deliver the placenta within 30 minutes of the delivery of the baby, because if it stays longer, then that could cause the mom to bleed out. Okay, so that's placenta. And yeah, that's what it looks like. You see the umbilical cord there. It's pretty cool. I mean, baby is cooler, I think, than the placenta. But anyway, that's what that looks like. So before we actually get to this image right here, let's talk a little bit about changes that the baby has to go through after it is born. So when the baby is being delivered, what they used to do, and I mean, they still do it unless you tell them you don't want to do it, is they would clamp the cord, which once you clamp the cord, this pauses the exchange of materials between the mom and the baby. So the gas exchange is no longer happening, or nutrient exchange is no longer happening. This will raise the carbon dioxide levels in the baby for a short moment, and this is going to kickstart their respiratory center and stimulate breathing. And so it's not necessary to spank the baby. Most babies will start breathing on their own if they're healthy. Another thing that stimulates the baby to cry could be just changing the environment. You're in this dark, sort of quiet, warm place. When you're born, you come into this bright, loud, cold place. Welcome to the world. All right. And so the baby will begin breathing as they're crying. They are expelling some of the fluid that was still in their lungs. And actually, during a vaginal birth, as the baby is being pushed through the birth canal and their shoulders are kind of squished, that also helps remove fluid from their lungs, because during pregnancy, there's amniotic fluid in their lungs at that point. But anyway, so the crying helps expand the lungs, and some fluid is also being removed from there that way. So that's that's um oh, blood flow, the circulatory system. So remember that we have that fossa ovalis in our heart, in the right atrium, and this was foramen ovale during fetal development. So because the fetus wasn't using lungs for gas exchange, the blood was going from the right atrium into the left atrium and then into systemic circulation. So most of the blood was skipping the pulmonary circulation because it was not necessary for gas exchange. However, when the baby is born, then this foramen ovale closes and becomes the fossa ovalis. And then we are starting to use that pulmonary circulation. Okay. So that's changes in the baby. Some changes in the mom. The change in hormones generally is going to cause the mom feeling this baby blues, which is just hormones are kind of all over place after delivery, and so it's just kind of feeling overwhelmed and just kind of uncertain. It's a lot of stuff ahead of us after we deliver a baby, right? But generally, this will balance out in, a week or two. It starts getting back to normal. But initially, even seeing a baby in the commercial will make you cry probably because, it makes you think of your baby. And anyway, so it's a very kind of emotional hormonal time after the delivery. Sometimes the baby blues does not go away and the hormones are just out of whack too much. And this could lead to postpartum depression. And postpartum depression is not the same as baby blues. It is actually a form of depression, which is like, this is when women might have negative feelings towards their baby. They might just not feel attached to the baby at all. They might have negative feelings towards themselves or other children. And this is a very serious condition which needs to be treated. I think sometimes women are embarrassed to say that they need help. But it's nothing to be embarrassed about. It's nobody's fault. Sometimes our body chemistry just doesn't go back to where it should be, and so it is very important to treat that, because that's not something that you can deal with on your own. You shouldn't. So seek help if that's if that's happening. The hormone drop is also going to carry with it hair loss. So remember all that hair that didn't fall out during pregnancy? Guess what? It's now going to start falling out. So, and sometimes it falls out in clumps for women, and it will eventually stop, but it can last for several months. If it seems like it's too much, it wouldn't hurt to have thyroid gland checked, because sometimes the thyroid does not go back to normal, and messed up thyroid function can also be a sign, or the hair loss could be a sign of that. The respiratory system, everything basically after the delivery, everything in the woman will slowly start going back to normal. And the women are hard on we're hard on ourselves. We're like, I want to be back to my pre-pregnancy body, next week after delivery. Well, that's there are women that walk out of the hospital and you can't even tell that they had a baby. But what we need to realize is that it took 9 months for our body to change. It took 9 months for our body to grow a baby. And so it should take at least as much to go back, if not more. My baby is 6 years old. I'm still working on it. So anyway, there is going to be prolactin and oxytocin spikes during nursing if the woman is nursing. And The oxytocin spikes actually help the uterus contract and kind of come back, return to its normal size. So the uterus now has to return to normal size. It's pretty large at this point, much larger than what it was before pregnancy, and so we're gonna experience the release of lochia, and lochia is a combination of extra fluid from our body, getting rid of this extra fluid from our body, blood, mucus, and endometrial tissue also. So it generally looks kind of like a really heavy period. Uh, okay, now this uterus is getting smaller and smaller, so all that tissue is coming out too, and that should be done by about 6 weeks after pregnancy. Some women it's sooner than that, but doctors do recommend that you actually do not engage in sexual intercourse during this time, and that's not because they don't want you to get pregnant right away. Okay, I mean they don't really, I guess, mind that part. Okay, but what's important to realize is that while the uterus is recovering, it is an open wound. You don't really want to be sticking anything in there, okay, or introducing bacteria in there. That's why this is recommended, is to abstain from intercourse until the uterus is completely healed. I don't know, who with a newborn, how do you have time for that? I don't know. So anyway, and this next picture right here shows us the lactation here. Lactation is the mother feeding her infant with the breast milk that's produced in her mammary glands. The breast milk is produced by these acinar cells that are organized in alveoli, and then it is passed to the baby. The stimulus for the letdown is the release of the breast milk. The stimulus for the letdown is suckling of the infant. That's the strongest stimulus. But initially, where remember your hormones are all out of whack initially, it could be just you thinking about the baby and then you feel the letdown, or you could hear a baby cry. It doesn't even have to be your baby. Letdown. Okay, so it's the most bizarre thing um, that happens, but eventually this will kind of balance out. I think about 2 months or so is when the mom's body and the baby's body kind of get in sync. The breastfeeding is very much a supply and demand kind of relationship, so the more that the baby is drinking, the more the mom is going to produce, and this is kind of increasing up until about 3 months, and then the breast milk composition will change. Okay, so like it's not like if you're breastfeeding for 2 years you're creating gallons of milk for every nursing session. No, it's going to be about the same amount of breast milk that the baby is going to be drinking every day, but it will be different in composition, so in concentration. What else about nursing? The composition of breast milk changes even from morning to the evening, and it does change as the baby is growing to meet its needs. So the mom's body senses or knows what the baby needs, and the composition will change. The There are like known growth spurts that the babies have, and during these growth spurts they will like nurse nonstop, so they will just have these cluster feedings, and that's to kickstart the mom's body to produce more milk. And I forgot at what weeks they are, but I think there's like one at like 2 weeks or something like that, and then there are different times when this happens. um, the milk, as I said, like it changes from morning to the evening, so like the morning milk might not be as concentrated as the evening one. The evening one tends to be a little more concentrated and dense, and so that like baby could sleep a little more. However, breast milk is so well digested by the baby, it's digested in about 3 hours no matter what. And so expecting a breastfed baby to sleep through the night, uh, early is probably not a very, very realistic expectation. So just wanted to kind of throw it out there. You know, we always compare ourselves with other people and say, well, their baby slept through the night when they were 2 weeks old. You know, that's probably not all that great either, because babies, like, their stomachs are not that big, so they need to feed often. And formula fed babies do sleep a little, like, through the night earlier, because formula is not as quickly digested. But breast milk, because it gets digested so quickly, they wake up because they're hungry. And so that's that. um, well, this finishes the lactation, and then now what's left is heredity. And so I have to check this video, but I should have a video attached with the worksheets, with the lab exercises that you're supposed to do, and that's where I'm talking about heredity. So watch those. If it by any chance mentions that you have to submit it on Google Classroom, remember, we're not submitting this on Google Classroom. We're submitting it through the Blackboard. Okay. Yeah. All right. Well, I'm gonna stop the recording here, if I remember how.